and I am a doctor in the clinic today. Can I confirm your name and age?
Yeah, doctor, my name is Daniel and I'm 41 years old.
Okay, Mr. Daniel, we are here to discuss about your health and examine you and answer your concern. Is that okay for you?
Yeah, sure. Go ahead.
Okay. Can you tell me why you are here today, Mr. Daniel?
Uh, the thing is, doctor, I'm having blood in my waterworks for the last 10 days and I'm quite worried about it.
Okay, I'm sorry, Mr. Daniel, for your complaint, and I will try my best to reach the bottom of this condition. Okay, and this is the first time you have, Mr. Daniel?
No. I've had problems with my waterworks for a long time now, doctor. I had a kidney transplant just last year. Uh, been having this, blood in my waterworks for a long time since I was a child. And then my kidney started failing. And just last year, I had the transplant. But after that, I haven't had this, bleeding from my waterworks. And now it started again. And I'm really worried about it.
Okay, Mr. Daniel, can you tell me any diagnosis for what is your initial problem before transplant?
I'm not sure, doctor. The thing is, since I was a child, I used to get, these uh, sore throats, and whenever I had the sore throats, I used to get uh, blood in my waterworks. And after some time, I started having swelling around my eyes and then around my feet. And then I went to the doctors, and they said that my kidneys were failing.
Okay. And this is a problem. After how many days you get this bleeding in the urine after the sore throat? It is a day or
That's
week?
well, it used to be like uh, a few days after the sore throat. Like if I got the sore throat on a Monday, this bleeding would start by Wednesday or Thursday in 2 or 3 days.
Okay. Okay, coming to your blood in your urine, and before 10 days you are okay. How it starts, suddenly or gradually?
Uh, it was sudden, doctor. I think it was quite sudden, and you know, uh, I when went to sleep the night before, I passed urine and it was fine. When I woke up, it was red.
Okay, and it is a fresh blood or black blood or cola blood?
No, it's reddish, doctor. I think.
Reddish. Any clot?
Yeah. No, there are no clots.
Okay. Is this blood come at the beginning of the urine or at the end of the urine or throughout?
It's throughout, doctor.
It is throughout. Okay. Any pain during passing this urine?
No pain.
It's no pain. Okay. Any froth in the urine?
No fault.
Any granules or stone?
No gravels, doctor.
Okay. Any pain in the area of transplant kidney?
Yeah. I think I'm having a bit of, you know, pain in there when I press on it, and it's a bit hotter than usual.
Okay. And if you scale the pain from 1 to 10, 1 is mild
It's a
pain and 10 is
it's a very dull pain, doctor, like a 2 or a 3, I would say. But when I press on it, it hurts a lot.
okay. It is going to anywhere?
No, it's just there, just on over the, where my transplanted kidney is.
It is came together, the blood in the urine and the pain.
Yeah, it started around the same time, I think.
Okay. Any buffness in your eyes?
No,
when you are awake in the morning?
no,
Any short of breath?
no.
Okay. And do you feel tired?
Um, yeah, but that's been going on for a long time, since my childhood because of the kidneys, and then even after the transplant, I've been tired all the time.
Okay. Any high fever?
No, no, I feel it. No,
Okay. Any change in your weight recently?
no, doc.
Mm. What is about your appetite?
My appetite is fine.
Okay. Any lump or bump in your body?
I don't think so.
Any muscle pain or joint pain?
No,
Any skin rash?
no.
Okay. Other than the transplanted kidney, do you have any other problem?
Uh, well, I've been uh, these past few months, I've been diagnosed as having high blood sugars also. So I'm taking a medication for it.
Okay. And it is controlled now?
Yeah, with the medication, I think it's called metformin. I don't know. I think that's the name. And my blood sugars are fine with that.
What is the last 3 months control of blood sugar?
I think it was around 7.
7. Okay. Can you show me your medication list?
Yeah, sure, doctor. Here it is. Okay, the patient is taking cyclosporin. He's taking a low dose of prednisolone, and he's taking metformin, and he's taking losartan and amlodipine.
Okay. And do you use any over-counter medication?
Not really, no,
Okay. Any herbal medication?
no,
Any allergy to any medication?
no, no.
Yeah. For those medication, do you any change in the dose, increasing or decreasing the dose?
Uh, yeah, the steroid that I take. Doctor, your 8 minutes are up. You can take a couple of more minutes to complete your history. Fine.
Okay.
Yes, doctor. When I had this transplant, a few weeks after that, uh, I was sick again, and they said that my kidney was being rejected, and I was, put on high doses of steroids. First, they gave it through the blood channels, and then they gave me the tablets. And now the tablets have been tapered down, and I only take one tablet of steroid.
Okay. Any recreation medication? I am sorry to ask this question.
No, no, never.
Any family history of similar problem?
No,
Any disease running in the family?
no.
Okay. And what is your job, Mr. Tanya?
I'm a school teacher, doctor.
And this is affected your job or your daily life?
No, no, not really.
Do you smoke?
Sorry?
Do you smoke?
No, I don't smoke, doctor.
Do you drink alcohol?
No, I don't.
Okay. Do you have any recent infection in the past weeks?
I don't know.
Okay. Can I examine you?
Sure, doctor. No.
Okay.
Okay, so this is your patient. Uh, what you want to examine, you can tell me step by step, and if anything is positive, I'll let you know. Okay. So first, you can tell me what you saw on the inspection. Hello, doctor, are you there?
Here is right abdominal scar.
Okay,
Okay. So I will start with abdomen.
okay, you'll start with the abdomen.
Okay, this is the scars, and I will examine the abdomen. Now, first by superficial palpation, if there is any tenderness or organomegaly.
There is mild tenderness over the scar.
Okay. Then I will examine, see if there is any mass under the scar.
Yes, there's a mass.
Okay. Then it is a tender.
It is a bit tender, yes.
Okay. Then I will percuss.
Okay, the percussion note is dull.
Okay. Then I will auscultate.
Okay. What will you be looking for? What do you want to hear
If
during auscultation?
if there is any bruit,
Okay. And if there is bruit, what would that indicate?
it could be indicates renal vein thrombosis.
Hmm. Renal vein or renal artery?
Renal artery thrombosis.
Okay. Yes. Okay.
Okay.
There is no bruit.
Then I will check for liver and spleen.
Liver and spleen are normal. No megaly.
Any ascites.
No ascites, doctor.
Then I will go for the hand to see if there is any
Okay.
clubbing,
No clubbing.
any tremor.
There is no tremor, doctor.
Okay. Any flapping tremor.
No flattened tremor.
Then I will check the pulse bilaterally.
Pulse is regular and at 92 beats per minute.
Then I will see if there is any previous fistula.
There is a AV fistula. You can see right here. It says left arm. How will you examine it?
Okay. First, I will look for any recent puncture. Then I will palpate for thrill
Okay.
or for any hotness. Then I will
Okay.
auscultate.
Right.
Okay. Then I will check.
So there is a bruit on auscultation.
But no recent puncture.
No recent needling marks.
Okay. Then I will check for proximal myopathy.
No proximal myopathy.
Then I will look for the eye, any anemia or rectus.
There is mild anemia. Anemia. Sorry.
Okay. Then I will look at the mouth.
Okay. Looking for what?
Looking for any ulcer, any cyanose, any infection, dental hygiene.
No. No ulcer. No cyanosis.
Okay. Then I will look for the ear, any hearing aid.
Okay. There are no hearing aids.
Okay. Then I will look for the leg for any JVB, raised JVB.
JVP is not raised.
Then I will look at any lymph nodes enlargement,
Okay. There are no lymph nodes.
any parathyroid scars, thyroid scar.
No scar for any thyroid or parathyroid surgery.
Then as you look for in the neck, any mark in the neck for previous dialysis.
There is a mark on the neck for a previous DLC.
Okay. Then I will examine the chest for any basal crypts.
No basal crusts.
Then I will auscultate the heart for any rub.
No friction rub.
Okay. So, Mr. Daniel, what is your concern?
What is wrong with me, doctor? Is it the same thing that I had previously that's come back?
Mr. Daniel, yes, from talking to you and examine you. Yes, I suspect it could be the same what you have before, but I have other possibilities, which could be you have uh, a rejection of the graft of the kidney, and other possibility could be infection.
Okay.
So what I want to do for you is to do some blood test, imaging, and after that, we refer you to the multidisciplinary team, includes the kidney doctors, who will give you a suitable management. And for the present time, I want to keep you in a hospital.
Okay. Okay. But am I going to be all right, doctor? I mean, I don't think I can find another kidney. It took me so many years to find this one. Is it going to be all right?
Okay, Mr. Daniel, yes, it is early to say everything here now. But if you didn't, from the examination, didn't find obvious cause, we may need to take an a snip from your kidney to see exactly what's happening.
Okay, doctor.
Do you have any other concern, Mr.
No,
Daniel?
doctor, that's fine. No, doctor, that's fine. Thank you. Okay, doctor. So please present your findings and then give me your differentials.
Mm. Mr. Daniel, who is 41 years old, with a previous history of kidney transplant, who is presented with hematuria. And from the history, I suspect that it could be an IgA nephropathy. That is, he is a previous recurrence following upper respiratory tract infection.
Okay, so you are saying that it was his previous the etiology for his kidney failure was IgA nephropathy, right?
Yes.
Okay, continue.
Okay, on examination of Mr. Daniel, I found the previous mode of chronic kidney disease treatment is hemodialysis in a form of fistula in his arm and a scar in his neck. He is mildly pale, and there is a scar in his right lower abdomen, long scar. Under this scar, there is a mass, which is tender, but there is no bruise. So my differential diagnosis of this patient could be recurrence of the previous disease.
Okay,
Number two could be infection. I am not asking about the trauma. I'm sorry. Any trauma?
okay. So your differentials are number one, it's recurrence of the
Yes.
disease.
Yes. Number one. Number two,
Okay,
it could be a rejection.
it could be rejection. Okay,
And number three could be thrombosis, renal thrombosis also.
renal vein thrombosis. Okay, anything else?
Mm, I can't. Something
Okay,
possible. Mm.
this patient is likely on immunotherapy, right?
Yes.
So any other differentials that come to your mind given that history?
I am not sure any toxicity of this medication can cause hematuria. I'm not sure.
But what could be the other complications of immunotherapy, immunosuppression in this patient?
Complication could be infection.
Okay, so please say that. It could be infections,
Yes.
right? Which
It could be
infections, doctor?
malignancy,
It could
especially
be
skin.
malignancy. Which malignancies, doctor?
Skin malignancy and solid organ malignancy.
Okay, so skin, solid organs. Any other malignancies?
Yes, both immunotherapy, lymphoproliferative disorders.
Excellent, doctor. Okay. And what about the infections? Which infections would he be prone to catching?
Like cytomegalovirus infection.
Yes.
And this is the most common infection.
Okay, fine. So, tell me, doctor, how will you investigate this patient?
First investigation, I want to confirm my diagnosis. I will do urine analysis, renal
Okay.
function test,
Okay.
ultrasound.
Hmm.
Then I will do drug level, and I may going
Then
to
you
take
then you'll do what?
drug levels.
Okay.
Then I may need to take a snip from the kidney biopsy.
Kidney biopsy. Okay.
Okay, then I will do general investigation in a form of full blood count, inflammatory marker, serum reactive protein, ESR, liver function test.
Right. Right. Okay. So, which investigation would help you differentiate these causes? The best investigation out of these?
Mm, I think renal biopsy.
Renal biopsy. That's right. Okay. So, how would you manage this patient, doctor?
Management usually educates the patient,
Okay.
multidisciplinary team, including kidney doctors, specialized nurse, and admission to the patient,
Yes. Okay.
and the treatment will depend upon which direction is the cause of this hematuria.
Right. Right. So, you mentioned you would admit this patient and then call a multidisciplinary team for him, right?
Yes.
So, tell me, doctor, what are the commonest causes of kidney failure in patients who come for transplantation?
This is depend upon the old patient and young patient. For the old patient, the common cause is diabetes mellitus, hypertension, obstructive uropathy.
Right.
And, and for the young, is a glomerulonephritis, number one, drug induced,
Okay.
and,
And
and vasculitis,
okay.
like SLE.
You're forgetting one cause in the young category also, doctor.
Glomerulonephritis. This is what is called with the hearing loss. I forget the name.
Alport syndrome
Harbor
and also doctor polycystic kidney disease.
Persistent. Sorry.
Right.
Yes.
Yeah. Okay. So, do you know about the types of rejections that a transplantation can face, doctor?
Yes, there is a hyperacute, which is occurring first 24 hours, acute
Okay.
and chronic.
Okay. And any specific points about these that you know, like what causes the hyperacute uh, rejection, what causes the acute rejection, and when do you
Hyper,
call it a chronic rejection?
hyperacute is usually due to incompatibility like HLA or OB incompatibility.
Right.
Okay. And in acute, usually following like infection, like toxicity of medication. And in chronic, this is I don't know about the chronic. I think it is type 4, something hypersensitivity.
No, no, both those, even type 4 is can be acute. Chronic is just the same thing, but happening very slowly and over a period of years. Okay, so well done, doctor. It was a very good case. Uh, you took a brilliant history. The examination was well done, and the differentials were spot on. A few things that I would like to point out that some examiners would cut your marks for, right? Going from physical examination, uh, you did not mention BP and a urine depth, right? This is a must in any renal case, and especially a kidney transplant case. You have to offer blood pressure and a urine depth at the end. You have to say, to complete my examination, I would like to check the blood pressure of the patient and order a urine depth for him, right? This is a must for this case. Other than this, the physical examination was spot on. Uh, Coming on to clinical communication skills, uh, it was well done. One thing I would have liked a bit more from you would have been to probe the history of the transplant a bit more, like who he got the kidney from. Was it a cadaveric transplant, or was it a live donor transplant? If it was a live donor transplant, was it a sibling or a close HLA, compatible individual or a HLA incompatible individual, right? And since transplant, has he had any issues with the kidney, right? Uh, and then the complication, you asked very well about the complications of renal failure in the patient, but you should have asked a bit more about the complications of treatment as well. We'll talk about it in a bit. uh, Other than this, the differentials were spot on. These were the differentials: recurrence of the disease, rejection, renal vein thrombosis, infections, and malignancies. Recurrence in this case, I would, put at the bottom, simply because the patient has IgA nephropathy, right? Recurrence of IgA nephropathy is usually after a few years, right? This patient just had a kidney transplant an year back, right? So recurrence of the disease would be a bit lower down on the list. If it was FSGS, yes, recurrence would be at the top, right? Then rejection, RVT, infections and malignancies, that those were fine. Coming to clinical judgment skills, perfect. Only two things were needed in this case. That was admitting the patient and calling an MDT, including the transplant team, right? Managing patient concerns was fine. Maintaining patient welfare, I would suggest that you need to have more empathy, doctor, towards the patient, right? If the patient is telling you that I'm very worried about this, I want, what if my kidney fails? I'm very worried. You have to acknowledge that, doctor. You have to, you know, uh, liaise with them. You have to uh, ease their worries a bit. You have to say that I appreciate your concern. I can understand this is very difficult. I'm here to help you. I will try my best to sort this out for you, right? Uh, Remember these phrases and use them in the exam. But overall, a very nice case and very well done. Uh, I want to, revise just two things. First, we'll revise the approach to examination of kidney transplant, and then we'll revise the approach to hematuria, right? So, in any patient who comes in with a renal, problem, be it in a abdomen case or in a long clinical consultation, if you see the patient and the patient is a renal case, right? There are 6 questions you need answered during your examination. What is the current mode of renal replacement therapy? Are there any previous modes of renal replacement therapies? And if there are any previous modes of renal replacement therapies, are they working or not? Number 3 is the renal replacement therapy adequate? Number 4, are there any complications of CKD in the patient? Number 5, are there any complications of treatment in the patient? And number 6 is, can I find the etiology of the renal disease? Right? These 6 things need to be addressed in the examination. So in this case, the current mode of renal replacement therapy was renal transplant, right? The previous modes were two. There was a, you know, DLC scar in the neck, and there was an AV fistula. When you see an AV fistula, you need to know the 2 things. Is it functioning? And is it still actively being used? Actively being used, right? How do we check the functioning of the AV fistula? The thrill and the bruit, right? And actively being used or not, we see for any recent needle marks, any recent bandages around the AV fistula, right? Then we come to, is RRT adequate? What do we mean by this? We mean, is there any acute complications of renal failure, acute renal failure, signs and symptoms of acute renal failure in this patient? What are those? Those
Repeat.
are, sorry, go ahead, doctor.
No, no, just go.
Okay. These are signs of uremia, fluid overload, and hypertension, right? Signs of uremia would be any altered mental status, any asterixis, flapping tremors, any excoriation marks from excessive pruritus, any tachypnea, any pericardial rub, right? Fluid overload, checking the bases of the lungs for any crackles, right? Hypertension, checking the blood pressure. Fourth thing is complications of CKD. What are the complications of CKD? Anemia, bone disease, hypertension, and uh, atherosclerotic uh, cardiovascular disease, right? So checking for any pallor, checking for any parathyroidectomy scars, things like that. Then complications of treatment. If the patient is on hemodialysis or peritoneal dialysis, checking for those complications. But this patient was on immunosuppression. So we need to check the complications of immunosuppression, right? What are the complications of immunosuppressions? It could be infections, it could be skin lesions, or it could be any uh, specific drug complications. In the skin, looking for any skin tags, checking for any warts, any lesions that could be squamous cell or basal cell carcinomas, right? Then checking for gum hypertrophy, checking for tremors, for cyclosporin and tacrolimus toxicities, checking for any pinpricks for you know glucose monitoring for diabetes, right? And then checking for lymph
ماشي
nodes
الكلام
for PTLD.
ادم بالظبط
Uh, just give me a
ماشي
minute.
الكلام انا مش رايحه راس البر انت ما الكلام ده انت قلت لي ايه انا قلت الادم يقفله انا بجيب
Oh, is my slide visible?
Yes.
يس
Okay. So then the last thing is etiology of renal disease, right? In the PACES, disproportionately, you will see if there is a renal transplant patient, uh, 50% of the time, the patient will be autosomal dominant polycystic kidney disease, right? So you need to check for uh, the native kidneys as well. Are they present or not? And if present, are they ballotable or not? What is the size of the kidneys, right? Other than this, Alport syndrome can be there for which you can check the, hearing aids. And yeah, and any other than this, diabetes could be the cause, right? Right. Okay. One other thing which is very important, whenever there is a transplant, you also need to know what happened to the native kidneys. You need to ask this in the history also, and checking the kidneys, both of them during examination is also a must to check if the native kidney was removed or is it still there, right? Because when we talk about what the problem might be right now, we can divide it into the problem might be with the graft, right? These all are problems with the graft, or it could be the problem with the native kidney as well, right? This solid organ malignancy that you mentioned as one of the causes, it could be that the native kidney that it was left in place has developed a renal cell carcinoma, right? So we need to know if there was a native kidney, is if it is present or not, right? Okay, so let's talk just briefly about approach to hematuria, right? Uh, are the slides visible, doctors?
Yes.
Okay. So whenever you get a patient with hematuria, uh, you have to ask two questions. Is it painful or painless? And is the patient above 40 or below 40, right? This is just a simplified, algorithm to keep in your mind. This is by no means, a definitive thing. Like cancer can occur below 40 as well, and pulmonary renal syndromes can occur after 40 as well. But this is generally how you should, frame your thoughts. So if it is painful, it could be a urinary tract infection, it could be a stone, it could be polycystic kidney disease. If it is painless, then under 40 or over 40, right? If it's under 40, think about glomerulonephritis, think about pulmonary renal syndromes, think about vasculitis. If it's over 40, think about cancer and also BPH. Then relation of the blood to the stream is very important in the exam only, not in real life, right? Because uh, real life is never this clear cut. So if the blood occurs at the beginning of the stream of urine, then it's urethral, uh, lesion. If it's throughout, then it's from the kidney or the bladder. And if it's only the terminal part, like the urine, when it is ending, then only the blood is there. Then it's the prostate. Okay, so what questions do you want to ask about the bleed? What was the color of the blood? Sorry, doctors. What was the color of the blood? Was it bright red or was it dark like cola? Why is cola colored urine important to rule out? Because it points towards acute intermittent porphyria, any type of hemolysis or obstructive jaundice, right? That is not true hematuria. Only if it is bright red is it true hematuria. Then we ask, are there any clots? What is the frequency? Is blood there every time you pass the urine or only now and then? And how much blood, right? Then timing in the stream, we already talked about. Is it at the beginning, throughout, or right at the end? Is it painful or painless? Is there bleeding from any other site? You failed to ask this question, Dr. Hassan. This is also an important question to find out if the bleed is, a systemic cause of the bleed. So you need to ask any bleeding from the nose, gums, or in the stool. Then asking about trauma. Did you have any injury to the back or tummy, right? Any recent procedures? Then you need to do a general review of the genitourinary system. What do you need to ask about the urine? You need to ask the frequency, the amount. Is it oliguria, polyuria? Was there any burning, mixture, burning, or any frothing? Has the patient passed any gravels? Is there any pus? Right? These are the questions for the urine. Then some questions for the prostate: hesitancy, incontinence, urgency, weak stream, dribbling. Right? Then asking about renal complications, signs of symptoms of overload like swelling of the ankles and the face, breathlessness. Then symptoms of uremia like nausea and vomiting. Then passing less urine, and then high blood pressure. Right? You need to ask these for complication. Then these symptoms, obviously, in any case, you need to ask any fever, weight loss, night sweats, any lumps or bumps anywhere on the body. Right. Now coming to the differentials. If it's painful hematuria, we discussed it already. It's USA. Urinary tract infections, stones, or ADPKD. Right. For UTI, you need to ask any fever. Is there any burning micturition? Right. Any frequency, urgency, burning micturition. For stones, ask about any previous history of stones and has the patient passed any gravel in the urine. Right. And if the stone history is positive, then you need to ask, then you need to, dive into whether it is hypercalcemia. Does the patient have other features of hypercalcemia, right? Then for ADPKD, anyone in the family having similar condition or any bleeding in the brain, right? Anyone had a transplant in the family. These two things also can present with the, polycystic kidneys. Tuberous sclerosis, you ask about any fits, any lumps on the skin or around the nails. For von Hippel-Lindau, you ask problem keeping your balance or difficulty walking, right? Then renal vein thrombosis and papillary necrosis can also be painful, right? Papillary necrosis is due to NSAIDs or diabetes, right? Renal vein thrombosis. Uh, if you think the patient is having renal vein thrombosis or thrombosis in general, right? This you need to ask the 10 clotting questions from the patient. Uh, Dr. Hassan, do you know about the clotting screen? What to ask if you are suspecting thrombosis in a patient?
Thrombophilic screening.
Yes, thrombophilic screening. What are the questions you would ask?
If he is passing red urine in the morning only, paroxysmal nocturnal hemoglobinuria.
Yes,
If he has history of clot before,
clot before. Yes,
porosity, and for Bahjat, mouse ulcer and genital ulcer,
right.
and for polycythemia, ask question, is there is any itching when you're at
Yes.
hot bath?
Hmm.
And there history of clot, bath history of clot. And if it is female, I will ask about the proportion.
Yes. Okay. So 10 things you need to, keep in mind when asking about any clotting uh, question. Any patient coming in with Budd-Chiari syndrome, patients coming in with pulmonary embolism, patients you are suspecting to be having renal vein thrombosis, patient presenting with, a painful cough, you're suspecting DVTs, right? So first is inherited, right? If any other family members have had clots, right, for inherited thrombophilias. Second is cancer, asking about the systemic symptoms, fever, weight loss, night sweats, lumps or bumps anywhere on your body, right? Third is myeloproliferative neoplasms, polycythemia rubra vera, right? What do you ask about that? You already told me. Itching after a hot shower, right? Facial plethora, you need to ask that. Then, if the patient is female, then pregnancy, contraceptive pills, right? You need to ask. Then, number six is APLS, any miscarriages in the past, right? Any previous clots. Then, number seven is nephrotic syndrome, any frothiness in the urine. Number eight is IBD, any blood in the stool, any joint pains, right? Any mouth ulcers. Then Behçet's disease, uh, again, mouth ulcers, then genital ulcers, right? Any problem with your vision or pain in your eye for uveitis, right? Then number 10 is PNH, uh, change in the color of urine first thing in the morning, right? So these are the 10 things that you need to screen for in any patient suspected to have, clots. Okay, then we come to painless hematuria. The mnemonic for that is CGPA, cancers, glomerulonephritis, pulmonary renal syndromes, or anticoagulant drugs. If the patient is over 40, you can add BPH as well. For cancers, we already know any lost weight, any lumps or bumps. For glomerulonephritis, uh, asking about sore throat because mostly this is going to be either PSGN or IgA nephropathy, right? And if it is IgA, the hematuria starts within a week, within 2 to 3 days of the sore throat. If it is PSGN, it starts after 2 weeks, right? For Alport syndrome, you ask any difficulty with your hearing. For pulmonary renal syndromes, you ask, have you coughed up any blood? Sorry. For vasculitis, low-grade fevers, weight loss, appetite, joint pains, right? Pulmonary renal syndromes. Four that you need to know: GPA, eGPA, SLE, and good pastures. So for GPA, you need to ask sinus infections, and for eGPA, asthma, right? For lupus, any rash, any mouth ulcers, any hair loss, anything from SLE you can ask, right? To differentiate between these pulmonary renal syndromes. Now coming to hematuria after a transplant. What are the five main causes? either infections, either renal vein thrombosis, either transplant rejection, acute or chronic, or recurrence of the original glomerulonephritis, right? Infections could be normal infections that the patient is having, like UTI, pyelonephritis from normal everyday organisms from community acquired causes, but that those are more common than patient having CMV or PK poliomavirus, right? Uh, and the patient is immunosuppressed already, so he's more susceptible to have those infections. So either it's that or it's an opportunistic infection. CMV, HSV, adenovirus, BK virus, JC virus. You you have to name CMV and you can name any other of these, right? But CMV you have to name. And then fungal infections could be Candida, Cryptococcus, Aspergillus, right? And if it is not an infection, then it's either a malignancy, could be a solid organ, could be PTLD, post-transplant lymphoproliferative disorder, or it could be a skin malignancy, right? Like squamous cell carcinoma, basal cell carcinoma. Then it could be drug induced. It could be recurrence of the disease, which is IgA, FSGS, SLE, good pastures, all of these recur. And others include chronic rejections, stones, ADPKD, hemorrhagic cysts, graft stent, right? So if the patient had ADPKD and one of the kidneys was removed and kidney was transplanted, kidney is still there, which has cysts, they could rupture. They could also cause, uh, hematuria. So always keep in mind that it could be a problem with the graft kidney or with the native kidney, right? Both could be affected. Uh, and I don't think this is really that much necessary, but if the patient comes in under a month after the transplant, then you're thinking about any nosocomial infections, UTIs, donor-derived infections, C. diff infections, right? If the patient comes in after 1 month, then it's the opportunistic window, CMV, BK virus, right? Mycobacterial and fungal infections. And if it's after 6 months, then the community-acquired infections come on top, right? The normal E. coli and those things come on top because the patient is immunosuppressed, right? It could be CMV still, it could be PCP, it could be BK, and it could be PTLD after 6 months, right? Okay, I think that just about covers it. If there are any questions, please feel free to ask.
Hello, doctor.
Yes,
Okay, I'm sorry because my connection. Okay,
no problem. I can hear you.
okay. What is the difference between acute, hyperacute, acute, and chronic? Sorry, I'm not hearing
Sorry.
the cause of acute, hyperacute, acute, and chronic.
Okay, so hyperacute, as you know, is due to it occurs when the rejection occurs minutes to hours after the transplant, and it is solely due to HLA incompatibility,
Due to what?
right? HLA incompatibility,
HLA. Okay.
right? Acute is due to either T cell mediated or antibody mediated, right? Uh,
Okay.
and these occur within the first months to 1 year. That is an acute window. It could be T cell mediated, it could be antibody mediated, right?
Okay.
And then chronic is after one year, and it is it slowly progresses. It has proteinuria, it has hypertension, and it slowly causes rejection. You need differentiating chronic rejection from recurrence of the disease is very difficult. You need a biopsy to differentiate them because they look alike.
And what is the cause of chronic?
Chronic rejection is, either due to any, fibrosis or uh, a new onset glomerulopathy that has developed in the kidney.
Okay, the second question, you said IgA nephropathy will not recurrence during the first years.
Yes, IgA nephropathy takes time
Okay, and
because
what can
even
occur in the first years?
FS. Okay, so FSGS is the typical thing, which has a high recurrence rate within the first year. It won't present with hematuria, right? Because it's a nephrotic syndrome. But FSGS recurs about 60 to 70% of the cases have a high recurrence rate within the first year.
Focal segmental?
Yes, focal segmental, yes.
And what is the other?
Other, good pastures is one. Alport's is one of them. That if the patient of Alport syndrome gets a kidney transplanted, right?
What is the
He develops.
post-glomerular?
Sorry.
Post-streptococcal glomerulonephritis?
Doctor, if
Uh,
you write these all
I
things
don't
in the
understand.
AI, you will find these all the causes in the very good, list. Better to ask the good questions like to have you have to face in the MRCP. These questions can you find in the books and everywhere. Why don't you gonna to ask what is a good scheme in an examination for a transplant patient? This is a good question where you will not find anywhere.
Yeah, that's
Okay.
fine. No, gaining knowledge from anywhere, you can ask any kind of question. That's no problem, doctor. So I forgot your question. I'll just recap it. FSGS, post-streptococcal glomerulonephritis, SLE, Alports, those are the things that recur within 1 year. Uh, IgA nephropathy takes some time to recur. And any other questions?
Okay, thank you. Thank you, doctor.
Yes, doctor, there is a question. Give us a very
Yes.
simple approach in an examination, how to examine a patient with a kidney transplant.
Okay. Let's revise that. We talked about this already, right? If you were here, you would know. We need to answer 6 questions, right? First, the current, this is not just for kidney transplant, this is for any renal case. Renal cases in PACES are very simple. They are free marks for you because all of them have the same scheme. Be it any hemodialysis, be it any renal transplant case, any case, they have the same scheme. 6 questions you need to answer. What is the current form of replacement therapy? What are the previous forms of renal replacement therapy? Is the renal replacement therapy adequate or not? Are there any complications of chronic renal failure? Are there any complications of treatment? And is what is the etiology of the renal disease? These 6 questions you need to answer during examination, right? So, looking at the patient, you walk in and you look at the patient, and he has a J-shaped scar, right, uh, on his abdomen. You, uh, at that moment, you know this is a kidney transplant patient, right? So, most probably in the exam, this is going to be the current form of treatment, right? They will not give you a trick patient in the exam that has that transplanted kidney, which has stopped functioning, and the patient has now come in with, acute kidney failure. That patient won't be in the exam. The patient would be stable. So you know for a fact that this is going to be the current form. Then you need to hunt for other forms. Is there any AV fistula in the patient? If there is this functioning or not? And has it been active or not recently, right? Functioning, you check with palpation for any thrill and auscultating for bruit. Then adequacy of renal replacement therapy. For adequacy of renal replacement therapy, you need to check whether the patient has signs of uremia, whether the patient has signs of fluid overload, right? And then complications of CKD, whether the patient has anemia or not. Then complications of treatment. Uh, are there any tremors in the hands? Is there any gum hypertrophy in the patient, right? Any signs of diabetes in the patients that you can see? And then etiology of renal disease, you check the kidneys. Are they palpable, ballotable? Are they increased in size or not? Is there any hearing aid you can see in the patient or not, right? And then when you come to the scar, when you examine the scar, uh, the abdomen, you need to palpate along the scar, right? Checking for the mass. Uh, and when you find the mass, you need to check, estimate the size, estimate the consistency, right? Uh, just 1 minute, doctor. Okay, sorry for that. Okay, so when you come to the mass, you need to estimate the size, estimate the if see if it is tender or not. What is the consistency? Then you need to percuss over it, and then you need to auscultate, right? I hope that clears your question.
I have a question, please.
Sorry.
Can you draw just a shape, common shape of scar of renal transplant? How many shape of scar we can find in the exam?
Doctor, to be honest, I didn't understand what you said. I am assuming you were asking about the scar for the kidney transplant, right? So if it's just a kidney transplant, it's going to be a J-shaped scar. We call it a Rutherford Morrison scar, right? A J-shaped scar. It could be on the left or the right side. It could be on both sides as well, right? If it's on both sides, you need to keep in mind that maybe one of the transplanted kidneys got rejected, or there was recurrence, it failed, and then there was another transplant, right? So maybe it could very well be two transplant scars you find in the patient. If the patient has tenderness, will we still percuss over it? No, doctor. You will ask the patient because you know the patient will be a real patient in the exam. He will be having the transplant, and transplanted organs are very precious organs. So you need to ask the patient first, is there any pain over your scar? Uh, if he says there is, you turn to the examiners and you say to them, the patient has pain over the scar. Should I still proceed? And they will most definitely say no, right? So you need to be careful. Even if the patient doesn't say that he has pain, you need to be very careful. You need to be very tender with that part of the examination. If you're a bit rough, the examiners will cut your marks in patient welfare. Any other questions, doctor? Okay, so with that, I think we can conclude this session. If there are any other questions, you can ask in the group also, right? Thank you, doctors, for participating.